everyone. Um, Thanks for staying until the end. And sorry, I'm a little bit in informal clothing, but since Sammy puts us to work out, I feel that was appropriate. I felt that was appropriate. So we'll be talking about, sorry, I'm in this age that I never know if I wear the glasses or not. It started a few years ago. So we'll talk about the updates from oncology, GI oncology. I pick up these abstracts in the ASCO GI. They break down in HPV, upper GI, and colorectal. But I'm sorry for my colleagues, they love other diseases, but colorectal was really the main highlights of ASCO GI. So we'll talk about a lot of them, and I'm going to use the strategy that Dr. Wells Misman did on his discusses. So we'll start with this. So 41 years old woman who presents with months of abdominal pain, rectal bleeding, and iron deficiency anemia. You know, she thought it was her hemorrhoids, that's why she had the rectal bleeding, and she never thought, because she was so young, that she could have cancer. So when fast forward, she had some workup done, CTs that show mass in the sigmoid in the left side of the colon, as well as bilobar liver mets, and the biopsy was adenocarcinoma. Molecular testing reviewed the following, and then that's where we're going to play with the three scenarios. A BRAF positive with a V600E mutated tumor, which is MSS or MMR proficiency. So, you know, now we have the data from the Breakwater study that look into the idea of using the Beacon regimen along with chemotherapy for the patients that have the BRAF mutated tumors in our metastatic colorectal. This is because we're already using in second and third line. And then in the design of the study here, they focus in comparing the combination of intragafnib and cetuximab with modified FOLFOX versus the standard of care of the patients, and that's what they reported here. Patients had to be adults, have to be metastatic disease, MSS disease, and so forth, and they couldn't have used any prior BRAF inhibitors. There was a dual primary endpoint incorporating objective response rates and progression-free survival as well. The characteristics of the patients are listed here. There was good balance between the distributions, and obviously, as expected, we saw a little bit more of patients having right-sided disease versus left-sided. In terms of the response rates, you can see here that with the incorporation in the first line with chemotherapy, the response rates were higher in this patient population. And in fact, there was improving response rate by 20% points. It was a double in the rate of durable responses with using in first line, as you can see here. In terms of the subgroup analysis, there was favor in most of the subgroup analysis incorporating there, regardless of the patient's characteristics. And there was a very strong trend to benefit overall survival. This is an interim analysis. The data is not fully mature, but you can see here that the curves separate extremely well. And when we look at the median overall survival has not been reached for the combination, and when we just look at standard of care chemotherapy, the median overall survival was 14 months. In terms of adverse events, there were the ones that we usually expect to see, with a little bit more issues with rash, which can be bothersome to many patients. There was a total of 23.8% of the patients had issues with the rash, given the TKI combination, and a little bit more arthralgias as well. In terms of those modifications related to side effects, obviously there had to be those modifications with cetuximab and encorafenib, but when we look at those modifications related to chemotherapy in both arms, there was not a big difference between having to do those adjustments in the chemotherapy portion in both arms, as you can see here. So the conclusions of the study is that the breakwater study did show a statistically significant and clinically meaningful benefit of overall response rate, which was one of the dual primary endpoints of this study. Also, the response was rapid and durable. There was also some preliminary improvement in the interim analysis with overall survival as well. And the final conclusion is that the combination should be considered as a new first-line treatment for patients with BRAF V600 mutated colorectal cancer. So in going back to our patient, now what we should do with this patient, indeed, we should consider using this regimen of encorafenib, cetuximab, and FOLFOX as the first line. What we don't know if it will be different if the patient has a different BRAF mutation, which is rare but not impossible to see, and whether we should continue the BRAF inhibition beyond progression. Right now, the answer is no, but we don't know if that can change based on potentially few studies that are coming up. Then we have our scenario number 2. What if this patient actually had a BRAF mutated but had a MSI high tumor? So that's when we go to the data that we have from the CheckMate HW, which was the results of nivolumab and ipilimumab versus nivolumab alone in patients with MSI high metastatic colorectal cancer. And the background for this is that we know that single agent checkpoint inhibitor is already showing promising results. Pembrolizumab has been approved. We don't know how much is better than potentially a dual combination of IOs. So the trial was designed to look into that, and this was a phase 3 study that was multicenter and open label, randomizing 3 different cohorts. Here they are focusing the review of nivo by itself versus nivo plus EP on this group. The patients could be treatment naive or not, and there was a stratification for that. There was a dual primary endpoint with progression-free survival as one of those, and based on the blinded reviewed. And the patients were treated up to 2 years. This is the characteristics of the patients. They were very well balanced. And one thing that I find interesting, do I have a pointer? I do. So is that, when they look into central confirmation, not every single time that the tumor was felt to be MSI high, actually on central confirmation it was. So I just find something interesting. It doesn't necessarily affect the results, but just to point on that. Here the progression-free survival benefits that we see, and you can see something here that's really nice. There's a separations of the curve really right in the beginning, like by month number 3, and that continues to the course of the time being, and that's positive at 12 months, 24 months, 36 months, and so forth, with the median progression-free survival of the combination not reached on the nivo-EP arm, and 39.3 months with the nivo. The response rates are also listed here. The complete response rate was fairly similar, but the overall response rate, when includes the partial response, are a little bit higher with the combination. When we look at the subgroup analysis, it really was persistent, regardless of the subgroup that you look, including patients with liver only disease or peritoneal disease. There was a trend on that, and same with regardless of other molecular markers that the patients had. In terms of the duration, I mentioned a little bit before, overall response rate 71% versus 58%. Complete response rates were similar, and time to treatment response was nice at with both arms at 2.8 months median. In terms of adverse events that are seen, there are certainly more toxicity with the dual treatment, particularly with more grade 3 and 4 toxicity that we can see. The overall numbers are not super high, but again, we certainly see there is more toxicity with the combination. And when we look at the toxicities that are a little bit higher, you can see here the usuals with diarrhea, rash, a little bit of pneumonitis, and so forth. Again, they were not super high numbers, but they were present. What is nice is that there was no deterioration of the quality of life with immunotherapy, and if anything, in the end, we see an improvement of quality of life with immunotherapy, which is refreshing to see. Typically, we just celebrate studies that show quality of life when there is no deterioration of the quality of life. So in conclusion, the study showed that the combination of nivolumab and ipilimumab demonstrated a statistically significant and clinical meaningful improvement in progression-free survival of these patients with MSI high tumors. It lasted for a long time, and they felt that the amount of side effects was manageable, and there was no new safety data that was seen. Quality of life are improved to both, and the argument is that it should be considered as a potential new standard of care for these patients. So going back to our young patient here, now you can consider using this strategy if the patient is willing to be exposed to a little bit more toxicity. And then what is unclear is that how long we should need to do. The trial did it at 2 years. Should we keep going? Should they stop at 1 year? There's argument that we can even use for less. And the other thing that we don't know right now is that if the patient progresses with monotherapy IO, is there a role to then combine and give the ipilimumab, and that could potentially rescue the patient and get the patient to have more responses. These are things that we don't know yet. Then we are going for our third scenario, which is if she had RAS and BRAF wild type and is MSS disease. So that's the final analysis of our deeper study, which look into modify FOLFOXIRI plus cetuximab or bevacizumab in this patient population. And this is based on the background, and you see potentially these deep responses, but the preliminary data didn't really show a lot of difference in the progression-free survival. The study design was done here. Again, patients have to have RAS wild type metastatic colorectal, ECOG performance of 0 to 1. If they were older than 70, they have to have ECOG performance of 0, and they allow for right and left tumors, but they did stratify by that. The 5-FU dose here was what we typically do in clinic, which was the 2,400 milligrams per square meter. I'd never go with the 300,000 dose. In terms of the consortium diagram, you can see the distribution of the patients, and what is important when it comes to the left side, how many were BRAF negative. You can have it here in each group. The characteristics of the patients was distributed here. Nothing very different among the both groups. When we look at progression-free survival with all the patients, you do not see a difference in median progression-free survival between the groups, neither with right side or left side. When we look at overall survival, again, there is not a statistically significant benefit, but you tend to see overall a trend of benefit of overall survival, despite the fact that was not statistically significant. When you break down in progression-free survival and overall survival in patients that are RAF, BRAF wild type and left-sided, that's when we start seeing a little bit of a difference here. When you use the triple chemotherapy with cetuximab, the median progression-free survival was 14.8 months versus 11.9 months. And when we look at overall survival, there was 50.2 months versus 40.2 months here, which even though there was a difference in the trend, you can see that in the curves, there was not statistically significant small cohort patients, but we can see this trend. And the deep responses were a little bit higher with the use of cetuximab. Overall survival, that's another thing that was interesting, this limited subgroup analysis, because the numbers are limited. But when we look at patients that had liver-only disease, the overall survival was the same between the groups. But in the other patients that did not have disease that was only confined to the liver, there was a benefit with using cetuximab here, with the median overall survival of 50.2 months versus the 38.6 months. Again, these are smaller subgroup analysis, but it's just something interesting to see. In terms of safety, I think not surprising, we saw more rash with the use of cetuximab instead of bevacizumab, and these were one of the main things. And diarrhea and hypertension, I'm sorry, was more seen with the bevacizumab as well, and a little bit of the more diarrhea with the cetuximab. So in the final survival analysis, they saw that the progression-free survival was significantly better with cetuximab versus bevacizumab in all this. There was not statistically better unless you are thinking about the patients with the left-sided wild type. And that's similar when you are thinking about breaking down by extrahepatic versus hepatic lesions. So the takeaways that they show that demonstrate a progression-free survival and overall survival with the incorporation of cetuximab in the wild type RAS, BRAF, and left-sided metastatic colon cancer, and could be an option for some patients, particularly if they have extrahepatic disease, right? Because that's when we saw the statistically significant benefit in the smaller subgroup that had extrahepatic disease. So for this patient, particularly here, the question is no, probably not, because this patient was only had limited disease in the liver, and especially if you take in context prior studies that have been done into this, the guidelines still continue to use double agent plus your EGFR antibody. However, if you need a deeper response, you might argue that perhaps there might be an option for such patient. The takeaways here from the colorectal partly metastatic is now for first-line BRAF mutated patients that are MSS. We should consider incorporating encorafenib and cetuximab with FOLFOX. Also, we should, for patients that are actually MSI high, we should consider incorporating the dual checkpoint inhibitors for this population. And when we talk in terms of adding cetuximab plus chemotherapy in first line, in the context of the triple therapy, the benefit is smaller, and I don't think we are ready for that yet. Then we'll jump gears to the adjuvant setting in colorectal cancer. This is update of the bespoke study. They're looking to incorporating ctDNA detection with a personalized assay, which commercially available Signatera, in patients that were monitored and whether they received chemotherapy or not for stage 2 and 3 disease. This was an observational study. The samples were collected before and just after surgery, and then sequential to several weeks and months post treatment. They started with more than 1,700 patients, and the final analysis for the stage 2 and 3 were 1,166 patients. And of those, 694 received chemotherapy and 472 were incorporated to observation. This is the characteristics of the patients in terms of the initial staging. 55% or 56% were stage 3 and 44% were stage 2. And most of the patients, thankfully, in general, did not recur. Only about 16% of the patients recur. And in terms of which patients were positive after surgery initially for MDR was 8% of the patients versus 28% of the patients. And this is what is really striking in terms of deciding, looking to disease-free survival. The patients that were negative did extremely better in terms of disease-free survival compared to the ones that were positive after surgery. And that's true for stage 2 and for stage 3 disease. In terms of the first time point, this was also true when whether it was positive or negative in the first time point of surveillance. If they did receive chemotherapy, whether they clear by 3 months or 6 months, you can also see a difference in the positives and the negatives. When they look at a subcohort of patients that were that develop metastatic disease later to see that could help the patients. And they had few conclusions on that, including to the sensitivity of detecting this disease. And they really wanted to understand what was happening to the ctDNA when patients were going through the curative intent procedures that were listed here. These are the recurrent sites on these patients, and what I think goes along, which we have seen, if a patient has disease only in the recurrence only in the lung, we might have appreciate a little bit less of the positivity of the ctDNA. Same with peritoneal disease, which is something that we thought that we were seeing. But in this subgroup of cohort of patients with colorectal that had metastatic disease that was treated, ctDNA was felt to be potentially predictive of the adjuvant therapy on these patients. And you can see here versus if observation or not, if they were negative versus if they were positive. And you have the numbers here in terms of the adjuvant strategies and the numbers of positive and negatives versus the two, and when they were negatives, that is really very similar. So the conclusions is that this was the largest multi-center ctDNA study that was reported in the post-op ctDNA testing in the context of monitoring patients if they receive or not adjuvant strategies. It was very sensitive in detecting recurrence, a little bit less in the peritoneal and lung. And the serial ctDNA was associated with a higher rate of potentially curative metastasis-directed therapy if you monitor those. And consistent with different reports, the ctDNA positivity was highly prognostic of disease-free survival in these cohorts. And chemotherapy benefit was observed in the patients that were positive post-surgery, but not in the ones that were negative. And the clearance of the DNA predicted a better or not disease-free survival. So there is studies going on right now, try to understand if we should guide our decisions based on ctDNA, but we don't have the results of that of the stage 3 and high-risk stage 4. That's a corporative group study that's been going on. So in terms of the strengths and the weakness, I think obviously this is not a randomized trial. This is still a limited follow-up. There was a lot of heterogeneity in the population, but it really is a large study with real-world implications and was multi-center. So again, ctDNA MDR can be prognostic for these patients. It can help to predict whether or not it can help with managing liver disease in the ones that are going to recurrence, and it could be helpful in early and intense surveillance in some cases. And there was a whole discussion at GI ASCO about should we be incorporating outside of a clinical trial or not. I'm happy to have that discussion during the questions later. Then the final study that I will talk about quickly is in NETs, because it made it to the oral presentations, and I do take care of neuroendocrine tumors for a living most of my time, so I'm biased here. But so in terms of neuroendocrine tumors in GAP NETs, we typically use somatostatin receptors for first line, unless there's a more aggressive biology, and you can argue if there's a more aggressive biology, you should consider doing chemotherapy with CAP10 if this is pancreas cancer or pancreatic neuroendocrine tumor, or perhaps PRRT. There's another two study that shows that for patients that have grade 2 and grade 3 disease, you could consider actually starting with PRRT. This study wanted to see the role of everolimus in first line, and there was no study that looked into everolimus for first line, and the studies that were done were actually in second line and refractory. And this is the data on lanreotide through the Clarinet study that show the somatostatin analogs are effective in this patient population. So the study here actually incorporated everolimus plus lanreotide and compare with everolimus alone, which I think is what is basically destroying the study, if I may, is that they didn't include a arm that was just lanreotide. So it's hard to think this study is going to change your practice. We're just going to jump to the characteristics, and then the interim analysis for progression-free survival showed that with everolimus alone is 11 months for GAP NETs, and for everolimus plus lanreotide is 29.7 months. The 11 months is actually very similar to what we have in other everolimus studies in the refractory line. In terms of the most updated, same difference of results. Overall survival was not reached, which is not surprising if the follow-up is limited and these patients thankfully tends to live for a very long time. We wouldn't expect overall survival to be seeing any benefits yet. Objective response, that was interesting. Everolimus by itself, we don't see a lot of responses, but with the combination, it was 23% versus the everolimus by itself, there was 8%. In terms of the subgroups of PNETs versus non-PNETs here, you can see that there was a bigger benefit with the pancreatic group in terms of progression for survival with everolimus and lanreotide. When they break down in different other subgroups by Ki-67, the one that had perceived to be more of the benefit was the group with a higher Ki-67, where everolimus by itself continued to see the 11 months of median progression-free survival, but the everolimus with lanreotide was the 29.7 months. Intriguing. Again, I don't think I'm going to be changing my practice a lot, because if I feel the patient needs to start with something more aggressive than a somatostatin analogs, right now I probably will be doing PRRT. And actually there was a study that was presented 3 weeks ago now, and the European meeting, they're looking to everolimus versus PRRT, compare directly PRRT versus everolimus, and they include 15% of the patients actually were first-line treatment, and they was tumors that were a little bit more aggressive with a Ki-67 of more than 15%, and then in the group, it shows that PRRT was better. So even for this patient population, I do think I will not use this combination. Adverse effects, obviously, advance was much worse with the combination, not surprising. Whoever gives everolimus knows that is not an easy drug to give necessarily. But the conclusions of the authors is that it could be considered a first-line option for patients, particularly if they have some features of poor prognosis, such as the Ki-67. Again, I think we're missing a big arm here, which was lanreotide by itself. And that's what I have. The limitations we talked through the study. Also, they did not show any quality of life yet. And I think I already discussed this where we're going through the slides. And I'll thank you, and if anyone has any questions. I can see the light.
As you know, I don't really treat neuroendocrine tumor that much, but why was the study designed like that?
Yeah, so great question. That's how there was a Japanese study only, and within their health system, they thought that made sense. I feel ashamed because it's such a good opportunity to have done. I don't know, that there was a study that have been global. I don't think any investigator in the US will agree with that design. It was just some healthcare decisions that they made it over there.
Questions? All right, thank you, Dr. Soares.